Hello, we're going to discuss oxygenation next, and in this class we will discuss oxygenation as it relates to COPD. COPD stands for chronic obstructive pulmonary disease, a disease in which the airway is compromised by both constriction of the bronchus and by inflammation of the bronchus, and also sometimes by secretions that build up in the bronchial airway. Both of these things, or all three of them, cause a narrowing of that airway. The diseases that cause chronic obstruction are bronchitis, chronic bronchitis, and emphysema. And also, asthma is a comorbidity that often occurs with these two disorders. So COPD is a specific progressive disorder that slowly alters the structures of the respiratory system over a number of years. And in each of the disorders, there is irreversible damage and destruction to the lung tissue that affects the actual function of the lung. While COPD is not curable, it is a manageable disorder. It involves a lot of teaching, not only of the patient, but also of the patient's family or caregiver. And what we need to keep in mind is that COPD typically includes components of both bronchitis and emphysema, so it's not always just one or the other. So while COPD generally results from the repeated exposure to some sort of respiratory irritant or chemical that causes damage to the structure within the lungs over time, occasionally, and it's very seldom, you'll get a person who will develop a COPD as a result of one hardcore exposure to a respiratory irritant. And an example of that would be the use of chemical warfare during war. So COPD is that umbrella that includes both chronic bronchitis and emphysema. It used to also include asthma, but now it's considered just a comorbidity. So in summary, there are three separate processes typically that are involved. You have the chronic bronchitis, where there is persistent airway edema, there's excessive mucus production, and impaired airway clearance. And emphysema, there is a loss of the interstitial membranes and the airway support tissues, and that results in an airway collapse and a loss of alveolar surface area so that you cannot exchange CO2 and oxygen sufficiently. And then there's small airway diseases that cause bronchoconstriction. What you see pictured in the larger picture here is a patient who has chronic bronchitis and they have excessive amounts of bronchial mucus secretions. So you see that in some areas they actually have completely closed off areas of the lung because the bronchiole leading to that area has such a large amount of mucus in it. And so you have no exchange there of CO2 and oxygen. So you have bronchial inflammation and you have those copious amounts of secretion that are often quite tenacious, meaning sticky and non-moving. And what happens is, to cause this, is that these patients have frequent infections, lots of upper respiratory infections. And those infections cause this increase in secretions, and then the increase in secretions, and they can't cough them out as they should, and they've got the narrow airways, and so there's a limited airflow, you get air trapping, the lungs become hyperinflated. If you look at the cutout picture, you see the deflated alveoli that are beyond those obstructions or distal to those obstructions. So in those areas, the alveoli actually collapse because they cannot exchange the gases as they should. Pictured here, what you have is the chronic bronchitis patient that has been affectionately named the blue bloater. And the reason that they came up with this name is that the patient tends to have a dusky to cyanotic color. And that color is in part because of the hypoxemia that they have that causes that cyanosis. And it manifests itself first as a bluish tint to the lips and circumoral or around the mouth. You'll see that bluish tint. You'll also get it in the nail beds that are having a dusky color. And then also, these patients tend to have an increase obstruction in their lungs that causes their residual lung volume gradually to increase, and that's where we get the bloating part. So what we see in these patients is that change in color. We see recurrent cough, recurrent respiratory infections, a high sputum production, and again, that's one of the earlier signs, is that they start to notice, especially in the morning, that buildup of sputum, hypoxia, and the hypercapnia, or the increase in the CO2 levels, respiratory acidosis, and this is directly because of that increase in the CO2 levels, and the increase in hemoglobin levels, an increase in respiratory rate as they try to compensate. These patients will present with exertional dyspnea. Just early on, they'll have exertional dyspnea. After it begins to progress, the disease process, they will have dyspnea even without the exertion. They'll have dyspnea at rest, even while wearing oxygen. These patients tend to be heavy cigarette smokers. You will see digital clubbing in them at the ends of the fingers, and my suggestion to you would be to Google that. You can see some really good examples online of digital clubbing that are much better than what I can explain. Cardiac enlargement, as they try to compensate for the decrease in perfusion. And then they will use their accessory muscles to breathe, and they also this will lead to a right-sided heart failure with these patients. Here we have the patient who has emphysema. So rather than just the buildup of secretions that we see in the patient who has bronchitis, we may see that, but more what we see is that there is permanent enlargement in the alveoli. And not only is there enlargement, but there's destruction of the walls of the alveoli. So if you look, instead of to the left of that picture, if you look to the pictures on the right as we follow that chain, you have the healthy lungs, you follow that healthy lung down into the healthy alveoli, and you see that each one is surrounded by the walls or the septum. And those walls are intact, and those walls are clean and pink and healthy looking. And each piece of that surface of those alveolar walls is a place for exchange of CO2 with oxygen. As you move to the next alveoli, you see that in that sac of alveoli, there are particles that have become trapped there. In this case, it shows you the patient was a cigarette smoker. And so that nicotine and the carcinogens and the chemicals that are within the cigarettes have gotten stuck there in the alveoli. And so then we move from there into the next sac, and you see that the inflammatory response has kicked in. So you have those inflammatory mediators that have moved into the area, and they have been triggered and have started to try to break down those harmful particles that are there. Unfortunately, what happens as they break down those particles is that there can also be destruction of the walls of the alveoli. And so as they break that down, you see in the next picture that there's a little bit of a blackened area as those chemicals dissolve the alveolar septum as well as the harmful particles. And what you're left with in the end, if you look to the next to the last portion where there's that last sac, you have a large air cavity. You don't have all the individual alveoli with all the individual septa for gas exchange. You have one large area, and the outside of that is lined with carbon deposits. So you no longer have any healthy area within that whole sac for air exchange to occur, or gas exchange to occur. And so that patient's capacity for gas exchange has decreased significantly. And if you look at the lungs up over top of that and you see all of the blackened areas, you can imagine that if all of those areas have lost their capacity for gas exchange, that person's respiratory capacity is going to be much lower and their perfusion is really going to be very poor. This is simply a picture, an actual picture from a cadaver of the lung, what it looked like after the patient died. And this is an emphysema patient. You see all of the holes where the alveoli have been burst out, if you will, where they've been eaten out by the chemical mediators and by the deposits that have built up there, and they lost their ability for any air exchange at all. And you see the balloons over on the right, and that's just signifying the bursting of those alveoli. On this next slide, you see the emphysema lung again, and you again see the buildup there as the air pocket grows. It impinges on the normal lung tissue and causes increased pressure, or bullae, or also known as blebs, as they form on the outer portion of the lung. And as these blebs burst, which is what they do, like those balloons, you're left with a hole there. And so that's why emphysema is also known as the vanishing lung syndrome.